first speaker is Dr. Victoria Werth. She's a professor of dermatology and medicine at the University of Pennsylvania. She's also chief of the Division of Dermatology at the Philadelphia Veterans Administration Hospital. Dr. Werth earned her medical degree from Johns Hopkins University School of Medicine in Baltimore. Her professional achievements include being recognized for her groundbreaking research in autoimmune skin disease, particularly in the area of lupus and dermatomyositis. She's published extensively in top-tier medical journals, presented at numerous scientific conferences, and we've all seen some of Dr. Werth's fantastic presentations at ACR, and has also received numerous awards and honours for her contributions to dermatology and autoimmune disease. And I would invite Dr. Werth, as I stop sharing my screen, to give her presentation today on diagnosing and managing skin disease in dermatomyositis. Dr. Werth.
Unmute myself. All right, share. Okay, so this is I love talking on this topic, and there's a lot happening as we already heard from Andrew. This is a very exciting time for dermatomyositis. There's just a lot happening. So I want to focus a little bit on the skin disease aspects and then some therapeutic approaches. Right. Let's see. I have to agree to be recorded or else I can't continue. All right. I do have some conflicts, which is good news, because that means without this help, we would never be getting new drugs in the future. And I was also involved in developing an outcome measure called the CDASI that looks at the skin activity and damage in the skin in people who have dermatomyositis. So in terms of diagnosis, and I will focus a lot today, more on some of the research that's going on, but I think diagnosing is very important. And pathognomonic would be erythema over the joints, usually hands, elbows, knees. It can be either papules or it can be a sign. And then characteristic findings are heliotrope, periungual telangiectasias, dystrophic cuticles, and photodistributed violaceous erythema. And so these are the things that we look for, and unfortunately not everybody knows about these, so there can be quite delays in getting a diagnosis. Now, the point of this busy slide is to say that there are people who have only skin disease or clinically amyopathic dermatomyositis, and the findings in the skin in those patients are exactly the same as what we see in patients who have classic DM, meaning skin and muscle. There's no difference in the findings. We know that in the past, and I'm sure there's been talk about this, but the bone and Peter criteria essentially required that you had to have muscle disease to be called dermatomyositis. As if you look down here, possible DM was if you had a rash and then one criterion, and all the criterion up here, the one criterion had to be muscle criteria. And what that meant was that people who had skin disease only really had a rough time getting a diagnosis because they did not fit into these criteria. So the diagnosis can be tough, and I'm sure many of you, it took a while to get a diagnosis, but for instance, people get called lupus. They can even meet lupus criteria with a malar rash, photosensitivity, positive ANA, oral ulcers. So really, without looking at the person and at their skin findings, you can't tell the difference a lot of times. And the biopsy doesn't really help. It puts you in the right category of lupus versus dermato, but it doesn't tell you which one you have. So we did a study a few years ago showing that about 55% of the patients that came into our clinic who had dermato were called something else. And the something else was lupus, undifferentiated connective tissue disease, 30% of the time, undiagnosed, and other. So this has always been a challenge. And now as we get it more, obviously for therapies, it's great to get an early diagnosis and to know what to look for. So with the help of Ingrid Lundberg, and I was lucky enough to be on the steering committee for this, we now have a better classification system for myositis. And in fact, you can recognize patients from their skin criteria alone as having dermatomyositis. If you have a heliotrope, Gotrin's papules, or Gotrin's sign, with 2 out of 3 of these, you can be given a very good possibility of having dermatomyositis. And this is truly an advancement. We know that about 73% or so, 74% of people with those three criteria, if you have two of them, will be captured as having dermatomyositis. And we did a study here from our database that showed that fact. However, there's still a little over a quarter of people who would not be classified as having dermato with just skin involvement. And so we've been trying to work in an international effort, which includes rheumatologic dermatologists and rheumatologists that are experts, to develop a more inclusive classification criteria for the skin. And so here you can see some of the morphology-based things like erythema on the skin, erythema around the eyes, papules, what we talked about over the joints. So these are the morphology-based. Then we have distribution-based, such as where are they located, symptoms. Obviously, itching is a huge issue, as well as photosensitivity, and then laboratory values. And so with those 23 criteria, we've now done a prospective study involving 14 sites, 12 dermatology, 2 rheumatology centers, clearly very worldwide. And we're comparing dermatomyositis to mammokers, and frequently these will be skin mammokers, testing these 23 potential criteria that were derived from a lot of work with Delphi consensus. And we've recruited 270 subjects, and that means 161 dermato and 109 controls. And finally, we're going to get to potentially a standalone criteria, which we're still working on. And then also to be involved with yet another iteration of improving myositis criteria. And we're working with the group that's leading this as well. Now, I think one of the things we would recognize, for instance, is that with the 3 criteria, we're not looking at things like telangiectasias or hemorrhage in the proximal nail fold, or for instance, a Shaw sign with erythema on the neck or in the back. So these things are not really captured, and not everybody has, as I said, those 3 findings, the erythema over joints, the papules, or the heliotrope. So I want to move on and talk a little bit about pathogenesis. And so this on the right is a skin biopsy. And what we see are all the things that I described on the left. We see inflammatory cells, these blue cells that are in the skin. Often we'll see some changes this is the upper layer of skin called the epidermis and the dermis, and we see these kind of vacuolated white areas, and that's part of what we look for. In dermatomyositis, you can see down here, this thickening, this red area is thickening of the basement membrane. And there are other findings that would basically allow one to categorize this biopsy as being consistent with either dermatomyositis or lupus. So then you have to go back and look at what are the skin findings to make a more definitive diagnosis. So the kinds of things that can be an issue are ultraviolet light, which I'm sure everybody is quite aware of. We heard about studies going on in genetics. They're type 1 interferons that are very important. These are inflammatory proteins that can drive disease and are turning out to be very important in dermatomyositis. And we'll talk a little bit about that. We talked about the inflammatory cells, those blue cells in the skin. We are interested in things that might be triggers or exacerbate dermatomyositis. And then there are antibodies. So in the skin and in the blood and the muscle, there's inflammation present. And we know that there's something called an interferon signature. There's certain genes that are upregulated by these proteins, interferon beta, interferon gamma to be exact. And these correlate with the genes that are activated in the skin and these other organs, muscle, blood, in patients with dermatomyositis. And this is just a fancy way of showing you that with increasing amounts of interferon beta, we're seeing that correlates with the score in the blood. And so what this means is that interferon beta, when it's more present, you're seeing a higher interferon score, and it's driving this inflammatory process, as is interferon gamma. So these are 2 proteins that are turning out to be important, and I'll show you a little bit more later about why that is important to know. We've done some work in my lab looking at what cells are in the skin, and we know that there are CD11C positive cells that are part of a dendritic cell class of cells that are part of the inflammation and can be drivers. And what's interesting is these are the plasmacytoid dendritic cells, a different type of dendritic cell, and you can see they're not very present in the skin. So again, why is this important? Well, there may be things that are, therapies coming along that are targeting plasmacytoid, these CD123 cells, and they're not in the skin very much. So there'll be a big question, is this going to be helpful or not? And we'll find out as we go along with studies. But these are the kinds of cells that you can see in the skin. And we've gone on and, for instance, looked at another cytokine. We talked about interferons. This one is involved with itch. And so we found that in the skin and people who itch, that there's increased amounts of IL-31, and that the IL-31 correlates with the itch that the person has. And so there are actually therapies that now target IL-31, but I think even better would be to find ways to turn off the inflammation overall, not not necessarily just the itch cytokine or protein. So we've gone on now and done some studies with tissue mass cytometry, and this is a fancy way of being able to look at like 40 different proteins at the same time with cell markers and figuring out what each cell, how many cells are there, that's what this E is, and what do these cells make? And so you can kind of figure out, well, what are the drivers more for interferon? You know, which cells are a problem? And this is a way of drilling down on that. So these are all the different cells that we saw, and the DM is healthy, is dermatomyositis, and HC is healthy control. And you can see in healthy control, we don't see much interferon beta, but we do see a lot here in dermato, and this is the myeloid dendritic cell I've been talking about. There's lots of interferon beta here, but you can see there are many cells that make interferon beta in the setting of dermatomyositis. Up here, you can actually see the interferon beta. It's staining in the skin. It's staining these red cells, which are the inflammatory cells that are in the skin that we're measuring over here. So these types of studies are going to be very helpful to be able to take apart, you know, what cells are important, and again, what cells are making the cytokines that are causing the inflammation in the skin. So I want to move on now and talk a little bit about herbal supplements. And this is something that I really talk about a lot. We initially became a little sensitized to this because not so much maybe, hopefully not so many people are on weight loss powders with their children, but we do see this in adults, and it has led to flares or new onset of dermatomyositis. But what's really important for children is I think that they avoid these immunostimulatory herbs. And I made a list of them here. Things like spirulina, which are in a lot of these green drinks, and you have to really read the labels. And you can, in blue-green algae can do a lot of stimulation of the immune system. So if you look on a bottle and it says this is an immune stimulant, that's probably not a good thing to take if you have dermatomyositis. We've noticed chlorella, in particular elderberry, which is really quite frequently used now, and ashwagandha. And we actually did a study where we looked at how many people with dermato, in this column here, were using immunostimulatory herbs relative to other autoimmune diseases. And you can see in lupus and other blistering diseases that are autoimmune or healthy controls, it was kind of a low level. But there was a lot more use in dermato, which to me could highlight that there's a problem, specifically in dermato, more than maybe other conditions, that's causing a problem. And here you're looking at spirulina, and again, much more use of spirulina relative to other autoimmune diseases or control. And we've done a lot of studies, and I'm just going to show you one of them. We've just published this paper here. But essentially what it shows you, or we took one type of cell, this dendritic cell we were talking about, and when you add spirulina to the cell, you suddenly get this big change in inflammatory cytokines. And we saw it for in two different cytokines, here and over here, with the cells that I showed you were in the skin. But look what happens with healthy controls. People who don't have dermato, they don't stimulate with spirulina. And we think there's a priming in the cells that really is causing problems for people. And we really advise avoiding these immunostimulatory herbs. So this is what we think is good to think about. Think before you drink, read the labels, very important. And I'll even point out that Robitussin now, there's a variant that uses elderberry, and there's also ashwagandha in melatonin. And it's amazing how these things are proliferating into a lot of the things that we take normally for our medical problems. Now, what about symptom progression? And so we did a study with 269 people who had dermato, half of whom had muscle and skin, and half had just skin. And one of the questions we get a lot is, how many people who have muscle involvement, what happens to the skin after the muscle is treated? And we found that 40% of the patients who had this muscle disease developed skin problems after their muscles went away, or didn't develop it, but it continued. So the skin kind of persists after the muscles sometimes get better, And the other thing that I think is very important to recognize is that the patients who started out with just skin involvement, only 5% of them went on to develop muscle. And that's something that I think we haven't recognized as much, but we know we have a whole cadre of patients who don't go on, even though they have the same skin findings, to get muscle problems. So that brings me to therapeutics. And this is an outcome measure that we spent many years developing, and basically measures activity in the skin based on the amount of redness, the amount of scale, erosions, and ulcers. And you get an activity score based on different surface areas involved, and you get a damage score. And so we've now been able to characterize what's mild disease versus moderate or severe, and what's an important improvement. And so these are the kinds of outcome measures you need if you're going to do studies that are looking at the effect of treatments, or look at just even the longitudinal, what happens within a disease. So that brings me to therapies, and first-line therapies would be sunscreens, and we advocate for SPF 70 or higher. 30 is great if you're trying to prevent skin cancer, but if you're trying to prevent photosensitivity, you need a little bit extra boost. A broad spectrum is good. Sun protective clothing, sun avoidance, meaning early morning, late afternoon, topical steroids, intralesional steroids. There's other topicals that can be used. And we do use animal arrows, although they don't work for everybody and they can cause a rash. But if that's a way of treating the skin, won't help the muscles, that can be beneficial for some people. And very frequently, we have to move on to second-line therapies, such as methotrexate or mycophenolate or azathioprine, and less often cyclosporin and tacrolimus. We try, obviously, steroids are needed for different patients at different times, hopefully not for a very long time. IVIG can be very helpful, and I'll give you some examples of that. And then tofacitinib, there's been one case series and some other case series that have looked at this, and I think we're awaiting results from a placebo-controlled trial. And then rituximab may help muscle probably more than skin. So one of the things about doing a trial that's important to realize, and this is a study we did where we looked longitudinally at the people we followed with Dermato, and we were looking at people who either took mycophenolate on the left or methotrexate on the right. And what you can see is that not everybody responds. The red people didn't really respond so well. The blues came down, but what I'm trying to show you is that it takes a long time to get better. So we're out here to 300 days. So if you're doing a trial and somebody was put on methotrexate or mycophenolate, they may be getting better, and that's part of the placebo response when you're trying to look at the effect of a therapy. And so it is important to have a placebo arm for studies. Now, the IVIG study was was an important trial that led to approval of IVIG for Dermato, and all the patients in this trial had muscle disease. And here you can see the mean treatment improvement score, which does look primarily at muscle, that if there was a pretty rapid improvement with IVIG relative to placebo, although when the patients with placebo got crossed over into the active arm, they caught up largely with the patients who got IVIG from the beginning. But this was an important study that also allowed us to look at the skin with the outcome measure that I just showed you. And here you can see the placebo response is not very much, which is great. And here is the response. And so there was a nice response seen that was even in very mild disease, you could see a difference between those who were in placebo and those who got drug, where it was a pretty rapid increase. Now, what I want to also talk very briefly here is that there are some experimental therapies that have been tried, in particular, linabacim, and also an ongoing phase 3 trial for anti-interferon beta. The linabacim study, it's a cannabinoid B, it's a 2 receptor agonist, and you can see here that in stimulated peripheral blood cells, you get a decrease in the interferon level when you add it to stimulated cells. This is what happened in the study. This was the arm that got that was not placebo, it got treatment. This was placebo, and you see it nicely separated. All these people had only skin disease, and unfortunately, in the phase 3 with muscle patients only, primarily, it failed, and it turns out that this drug worked more for skin than muscle. So we really have to look at these carefully. This is the kind of improvement we saw, though, before and after. With the oral linabacim that was pretty well tolerated. And that brings me to another study that there have been results that have been presented at national meetings. This is with anti-interferon beta. And here you can see that the patients got a huge improvement in their skin score relative to placebo. And there were 2 doses in this study, and again, much better in the 2 doses relative to placebo. So this is pretty exciting. And when you look at this over time, you can see that the 2 doses, the people got better, and it didn't take that long. And large improvement. I told you 40% is what's really important to patients, and people achieved more than that. And then this is the placebo, which again was pretty flat. And so what this is showing is that the percent responders is pretty high for both of these groups. And when you look at the greater than 40%, 80% of people got better in both of these treatment arms relative to placebo. So we're very looking forward to seeing phase 3 results with this drug. And there are many new approaches in the pipeline. There's an ongoing sub-Q IVIG study. There's different inhibitors of pathways that are important for interferon production. There are ways of clearing antibodies, and I'm sure we'll hear more about CAR T cells. So in summary, I would say we have a better classification system that does include those who have only skin involvement. We're learning more about dermatomyositis all the time. I would advise, no matter what, avoiding immunostimulatory herbs. We have a validated disease severity tool for skin, and there's really is exciting time because of the therapies that are in the pipeline. I want to acknowledge a lot of the people that have worked with me over the years on these projects, as well as some of the funding. And I think with that, that's my last slide, and appreciate your attention.
Thank you, Dr. Werth. And if people would like to post any questions they may have to the chat box, one of them has come up already from Suzanne Edison from the foundation. Are any of the patients in the trials adults who were diagnosed with JDM, or are they just adults with DM?
Yeah, I mean, each trial is a little bit different. And there are some trials that are excluding JDM patients, even though they're adults, which is probably unnecessary, but trying to get a more homogeneous population. I think what's really exciting is that the FDA is really becoming much more interested in studying children. And I think it's very obvious that there are a lot of similarities between adults and children. And so I would say stay tuned. There's going to be more and more studies. There's already been some. There'll be more in the future.
Question from Michael Miller. What's the theory behind some therapies better at skin versus muscle symptoms?
Well, that's a great question. I now have an NIH grant that's trying to understand, at least with the cannabinoid receptor, why that would be true. Most of our therapies, you know, I mean, there is variability, and I do believe that there's some differences in pathways that are activated in people who have skin-only disease versus muscle, and it's an area that we're actively studying, but it hasn't been much really published about that. There's a lot of heterogeneity in terms of the cells and their receptors, and so not everybody is going to respond the same to treatments, and that's why it's important to characterize not just the response clinically, but also to understand what are the differences from a more of a scientific viewpoint in responders versus non-responders to these therapies.
One more question from Trevor McCowan. Can you speak about anifrolumab, if I've got that pronunciation correct, an already FDA-approved type 1 IFN targeting drug in DM skin disease?
Yeah, I can. Anifrolumab is an antibody against the type 1, the IFNAR, a type 1 interferon receptor. So it blocks interferon alpha and beta. It's not clear to me that it blocks them equally, but it does block them. And there was a phase 3 trial in lupus that led to approval of the drug. And there's plans for an ongoing, or not ongoing, but plans for a trial of anifrolumab in DM, although that has not started yet. So I think that there's reason to think that it might be effective, but I think there's case reports, but not so much what I would call controlled data right now.
Given that we've got one more question from Stacey Tarvin that's just come in. We've got a few more that are coming in. We are sort of running out of time, but I think Dr. Tarvin's question is particularly relevant. Supplements and nutraceuticals come up all the time in pediatrics, and generally ask them to avoid them. Spirulina seems like it's a hard thing to run into unless you're actively supplementing with it. What diet suggestions do you give to families that aren't seeking out supplements but ask about other foods to avoid, if any?
Yeah, I would say if you start reading labels, you're going to be really shocked at how much spirulina is in different substances and foods. And so, if you get a smoothie, I mean, very often they can add spirulina if you want them to. It's in a lot of foods. And I think the main thing, and green drinks, our cafeteria, sells green drinks that have spirulina. And so you might not know that it's not really something, even a supplement. It's a food that's got this stuff in it. Some of them have all three: green algae, chlorella, and spirulina. So I would say, and in kids, you would say, well, that's not so likely. But I've had situations where, for instance, the gummies that have elderberry. I mean, the use of elderberry went up 400%. Right at the time of the lockdown of the pandemic. And a lot of people are taking elderberry. They have there are all these nice gummies and different things. And so I would say the advice is not so much about the foods, it's more what's in it and what's been supplemented, and also the supplements that people are buying. And I was really surprised when I went to the CVS store and there's Robitussin, which, and suddenly they're sticking things in it that really, I think, are an issue specifically for patients with dermatomyositis. It does make sense that an immunostimulant would not be a good thing.
I think we are going to have to draw it to a close there, but thank you very much for the presentation, Dr. Werth. Certainly, I think you've opened the foundation's eyes to something that we should actively be looking at around food and supplements and getting people to read labels. So we may be reaching out to you in the not too distant future for some advice on that, and maybe even roping you in for a town hall for our patients and families. I'd like to move on now.